Dear Chairman, dear colleagues, I would like to thank the organizing committee for the invitation. I will present you the essentials of the anatomy of the elbow, which is a synovial joint, including 3 bones. Many authors describe it as a hinge joint, allowing movement only in one plane, but it is more a compound joint, which includes 3 articulations enclosed in the same joint capsule. So some authors described it as a modified complex or loose hitch joint. The elbow adds mobility of the hand in space by shortening, lengthening, and rotating the arm, and it provides control and stability for skilled hand motion and for forceful upper extremity movement. It is formed by 3 joints, the ulnohumeral, the radiohumeral, and the proximal radio-ulnar joint. It is considered to be one of the most congruent joints of the body. The ulnohumeral joint is a hinge joint allowing flexion and extension, and it consists of a trochlea, which is a hyperbolic pulley-like surface with articular coverage of an impressive over 300 degrees. It has a large medial margin, which projects more distally than the lateral one, and it has a groove between the 2 margins crossing in a helical manner from an anterolateral to a posteromedial direction. It also consists of the greater sigmoid nodes of the proximal ulna and the olecranon on the posterior side of the articulation. The radiohumeral joint is a pivot-type articulation which allows rotation, and it consists of the capitellum, which is almost spheroidal in shape, and it's covered with a thick cartilage anteriorly, and the radial head has a cylindrical depression in the mid-portion to accommodate the capitellum, and the radial head has actually 240 degrees of the circumference covered with cartilage. The proximal radio-ulnar joint is also a pivot joint allowing rotational movement. It's responsible for the pronation and supination of the forearm. It's practically an articulation between the outside circumferential radial head and the fibro-osseous ring formed by the radial groove of the ulna and the annular ligament. Of course, it includes also the proximal part of the interosseous membrane. It's very important to discuss the joint surface orientation of the distal humerus. We know that in the lateral plane, this articular surface is located anteriorly about 30%, about 30 degrees with respect to the long axis of the humerus. Also, the center of this concentric arc formed by the trochlea and the capitellum is on a line that is coplanar with the anterior and distal cortex of the humerus. In the transverse plane, this articular surface is rotated inwardly 5 degrees and is tilted in the frontal plane about 6 degrees in valgus. Furthermore, the distal humerus consists of 2 columns of medial and lateral epicondyal ridges, and also a central one articulating axis, which is the trochlea. The medial column has at its distal end the medial epicondyle with the insertion of the flexor muscles and also the medial part of the humeral trochlea, and the lateral column has at its distal end the capitellum and also the lateral epicondyle with the insertion of the extensor muscles. The articular block of both columns forms practically an asymmetric triangle, which is it's the base for the stability of the distal humerus, and the lateral column has a teardrop cross-section shape, who resists better in forces of torsion, while the medial column has a triangular cross-section shape and therefore is susceptible to shearing and torsion forces. Regarding range of motion, the extension of the elbow lies between -6 and 11 degrees, the flexion between 130 and 154 degrees. Pronation varies from 75 to 85 degrees, supination from 80 to 104 degrees, and we have the so-called carrying angle, which is the angle formed by the long axis of the humerus and the ulna in full extension. In males, it's calculated between 11 and 14 degrees. In females, between 13 and 16 degrees. And in the normal elbow, we have a small degrees of valgus regarding this angle. A very important stabilizing element is the joint capsule. We have the anterior part, which sits proximally above the coronoid and the radial fossa, and distally it attaches to the anterior part of the coronoid and also the annular ligament on the lateral side. The posterior capsule, who attaches proximally to the olecranon fossa and then distally to the medial and lateral margins of the trochlea. The normal capacity of the fully extended joint capsule lies between 25 and 30 milliliters. We have also bursae, many bursae in the elbow. There are a few have clinical importances. The intratendinous olecranon bursa, the subtendinous olecranon bursa, which reduce friction between the triceps brachii and the olecranon, and also the subcutaneous olecranon bursa, the one which is implicated in the olecranon bursitis. Very important elements, the ligaments of the elbow, who provide stability during flexion and extension of the joint. We have the joint capsule, which is thickened medial and laterally to form the collateral ligaments. We have the medial collateral ligament complex, which is triangular. We have the anterior bundle, the posterior bundle, and also the transverse bundle, who contribute to stability. We have furthermore the lateral collateral ligament complex, which is narrower than the ulnar collateral and which is attached proximal to the lateral epicondyle and below to the annular ligament. Furthermore, we have the annular ligament, the anterior ligament, which is a broad and thin fibrous layer covering the anterior surface of the joint. The posterior ligament, who is thinner and consists of transverse and oblique fibers. The annular ligament, which is a strong band of fibers that wrap around the head of the radius and attach it to the radial notch of the ulna. It prevents any separation of the two bones laterally. It secures practically the head of the radius from dislocation, because this head would otherwise tend to dislocate due to the shallowness of the cup-like surface and also the tension of the biceps, of the tendon of the biceps brachii. Furthermore, we have the accessory lateral collateral ligament, which further stabilizes the annular ligament. Regarding muscles, we have the elbow flexors, the biceps brachii being the most important one. He is also a very good, very strong supinator in the pronated position. The brachialis, who has the largest cross-sectional area of any of the elbow flexors. The brachioradialis, and regarding extensors, the triceps with a long lateral medial head blending in the midline to form a common muscle that tapers into the triceps tendon in the tip of the olecranon. We have the extensor digitorum communis, who makes the most of the contour of the extensor surface of the forearm. The anconeus, who has a primary role as a joint stabilizer and is a very important anatomical landmark for in lateral and posterolateral exposures. The supinator, a rhomboid muscle without any tendinous tissue, which is very important for lateral exposures and also for the course of the posterior interosseous nerve in entrapment syndromes. The pronator teres, where we can have an entrapment of the median nerve, the anterior interosseous nerve. The extensor carpi radialis brevis, which is implicated in lateral epicondylitis, the carpi radialis longus, and all the flexors, carpi radialis, carpi ulnaris, the flexors of the digits, and the palmaris longus. Regarding the stabilizers of the elbow joint, we have the primary static stabilizers, which is the ulnohumeral joint, the coronoid process, which we know because loss of 50% of this coronoid height leads in elbow instability. The medial collateral ligament complex, who provides resistance to valgus and destructive stresses. The lateral collateral ligament, which is a primary restraint to varus and external stress. The accessory collateral ligament and the annular ligament. Furthermore, we have the secondary static stabilizers, the radiocapitellar joint, the radial head, who provides approximately 30% of valgus stability, the capsule, who has a great contribute in the stability during with the elbow extended, and the origin of the flexor and the extensor tendons in regarding varus valgus stability. Furthermore, we have the dynamic stabilizers, the anconeus, the brachialis, the triceps, and the biceps, who provide compressive stability. Regarding vascularization, arteries. You have the brachial artery who separates in the ulnar and radial artery at the level of the radial head. Vein supply is the brachial, cephalic, and basilic vein. We have the cutaneous innervation, as you can see there in the picture. And furthermore, finally, we have four main nerves crossing the elbow: the musculocutaneous nerve, who passes distally between the brachialis and biceps muscle. We have the radial nerve, who enters the lateral intermuscular septum at the distal third of the humerus between the brachialis, and then at the point of the cubital fossa divides into the posterior interosseous nerve and the superficial radial nerve. We know that this nerve in the arcade of Rosse can be entrapped. Furthermore, we have the median nerve, who runs in the arm, the cubital fossa medial to the biceps, and then enters between the two heads of the pronator teres and gives the anterior interosseous nerve. This is also a possible point of entrapment. And finally, the ulnar nerve that comes into the cubital tunnel posterior to the medial epicondyle and then comes into the forearm between the two heads of the flexor carpi ulnaris. So the elbow articulation involves three different joints. It's a compound and congruent articulation that provides mobility of the hand in space. It's stabilized by bony structures and the complex ligamentous, capsular, and tendon construct. The surgeon must be familiar with the anatomical characteristics of the distal humerus, and anyway, the knowledge of the entire anatomy of the elbow is necessary in order to understand any possible injury and to plan precisely any kind of surgical treatment. Thank you very much.